Thanks.
Yeah. So yes, just a last welcome to everyone here to SCI, and I hope that you've had a kind of interesting day hearing obviously a lot of different aspects of the work that we do. And what I'm just going to do now is a slightly unenviable task of just trying to kind of summarise that and perhaps leave you with a kind of a few of our goals going forward for SCI. So just to kind of remind you right back to the beginning from what Alan said of kind of the scale of the problem that we're looking at. And Alan said right at the beginning that there's 10 times more people that have schistosomiasis in Africa than HIV. And so we're looking at about 240 million people that are infected with this disease. And when we look at, rather than just the number of people, when we actually look at the burden of that disease, and we use this term that you may well be familiar with, of DALY, so these are disability-adjusted life years. So these are looking not only at the mortality of those diseases, but also the morbidity. So actually, in people's day-to-day lives, what is the burden of that disease? And so we've got quantification here, and you can see that for schistosomiasis and the soil-transmitted helminths that obviously our programs are targeting, 41% of all the DALYs for NTDs actually can be attributed to those four diseases. So we feel that we're really hitting a really big burden with our programs. But also, and to date, we have delivered, as you've heard many times, about 120 million treatments. And you can see there at the bottom of the bars just our kind of year-on-year treatment up to last year. But we also, sorry, I've lost a slide there somewhere. But also, as we heard from Albus earlier on, our global coverage for schistosomiasis is still very low. We're only still hitting about 40 million people, and that's a coverage of only about 14% of all those people that are actually at risk of schistosomiasis. So we still have quite a way to go. And as again has been touched on many times, we have expanded hugely from Alan's initial introduction to the Gates Foundation, where we're just looking at those 6 countries initially, to now looking at 16 countries. And we've diversified our donor base from just having initially that one support from the Gates Foundation to now having numerous different investors in different sectors. But we've really maintained our kind of core strategy through that massive expansion. And as Mike and Roy very ably demonstrated, we're making sure that we keep research and developing an evidence base at the heart of everything we do. And we're in a very unique position to be able to actually translate that scientific knowledge actually through into our programs on the kind of day-to-day level. And also, as we've just heard very interestingly from Narcis, we're very keen to support the capacity building within countries, and that leads on to our kind of sustainability of our programs and our real commitment to making sure that these programs are owned and led by the Ministries of Health and Education, and we just bring our abilities in technical support and also financial backing. So in terms of our implementation, we've obviously expanded hugely, but because of our commitment to sustainability of those programs, and again, as Albert said right at the beginning, we really have now got the challenge of scaling up. It's not around necessarily adding more countries, it's about really making sure that the countries that we're in are actually at scale, and also, as we've heard, that we move those countries from just morbidity control through elimination as a public health problem to hopefully the elimination of infection and transmission. And I think we're all aware of the challenges that incorporates. And also that we're ensuring that we're using the most cost-effective delivery methods. And obviously Anna kind of gave us the overview of how we try to do that in terms of integration and coordination with other programs. But also, as we heard from Narcis, we do have to make sure that actually we don't just create another vertical program which is called NTDs rather than a vertical program that was called Schistosomiasis. So again, we're working to see how we can work with a broader health system to really get these programs embedded into those health systems. But we do realise, and Anna highlighted several of these, that these are not necessarily simple steps. And although we have a huge willingness to do it, there's actually a number of challenges that we have to overcome if we're really going to put that into place. And I think Jane very capably went through at the beginning our monitoring and evaluation strategies, so that we are able to not only demonstrate impact to the communities that we're supporting and also to our donors, but also to ensure that we're very responsive to any changes that are occurring, that we can have mitigating strategies to make sure that our programs are as effective as they possibly can be. So going forward, as Alan mentioned, we've got quite an ambitious target of by 2018 to have actually doubled the number of treatments that we're giving to 240 million. And to maintain that sustainability approach, we're aiming not to add in more countries, but to really ensure that we're scaling up in those countries. And we've done some estimates. You can see the numbers there in red. These are the estimates of the number of treatments that we would hope to give in those countries between now and 2018. Now, obviously, there's quite a large resource requirement to hit that 240 million treatments. And as you've heard about before, we are very fortunate to be working with Merck Serono, who have very generously increased their donation of praziquantel from the 20 million per year in 2011 up to 250 million tablets in 2016. And obviously we're working very closely with WHO to coordinate that donation. But obviously, and also, as we've already heard, GlaxoSmithKline and Johnson & Johnson have also significantly increased their donation for albendazole to treat soil-transmitted helminths as well. And so that just gives you a little bit of a picture of our praziquantel donation through 2016, hoping to be able to treat 150 million people. But obviously there is then a gap between the donated praziquantel and our target for treatment. And so what we've tried to do is just to quantify the amount of additional praziquantel we would need to purchase and also financially support the delivery of those in country. And so now we've got some quite concrete targets in terms of our fundraising to be able to support those activities. And you can see that we have quite a large proportion of committed funds, which are primarily through our investment from DFID. But also we're kind of looking to raise between 1.5 and 200 million pounds on an annual basis to hit our 240 million target. We also need human resources to support that. And I don't think I need to say much because we've kind of showcased the really exceptional SCI team that we have here. But also we've been fortunate of working with Accenture Development Partners over the last few months, who are the not-for-profit arm of Accenture, really just to look at how we can optimise our programme management and financial and organisational structure, because obviously now kind of moving into a much more kind of complex funding sort of structure, and also with the increased number of countries we have, we really want to make sure that we're really optimising everything that we do. And finally, none of this could be possible without endemic country resources. And as we've all said a number of times, really we're very committed to this idea of country ownership and leadership, and also looking at actually how we can quantify to donors and other organisations really the resources that are contributed by country governments. And as sort of NASA's given you a nice overview of kind of all the different areas where we try and support ministries of health and education, but there is also obviously a huge contribution from those countries, often in kind, but that we do really need to capture if we're going to look at a kind of holistic approach of who is actually supporting these programmes. Again, we're obviously very committed to provision of technical assistance from our UK-based programme managers, and obviously from our capacity building based in Uganda. But we're also looking really with feedback from the NARCIS and others around countries that we're working in that perhaps have quite low capacity currently, or are particularly complex settings, very sort of large countries or countries where we have multiple donors, actually to start looking at perhaps a slightly different model where we actually support in-country managers to provide a kind of ongoing sort of day-to-day assistance to the Ministry of Health, which is obviously always backed up by programme managers within the UK. So really that's all I wanted to say, and just to say thank you very much for coming to talk to this afternoon, and also I know that in fact everyone here contributes to SCI in some way or another, so just this opportunity to thank you for that.